is the second event in the series of provider education that is jointly provided by the University of Nebraska Medical Center and the National Hemophilia Foundation. Today, we're going to be discussing provider and patient communications for shared decision-making when providing healthcare for women, girls, and people with the propensity to menstruate. This program will provide opportunity for you to engage in interactive conversations about the topic of shared decision-making when providing treatment for women, girls, and people with a propensity to menstruate when you are managing their clinical bleeding disorders. My name is Marcy Hardy. I'm the Manager of Medical Education Grants at the National Hemophilia Foundation. I'll be your moderator for this session. If you have any questions or concerns after the session that you would like to share, you can obviously do that during the chat. But if something comes to you even later, feel free to reach out to me and email me, and I will try to get that question or information for you. Our presenters today are Dr. Maureen Baldwin. She is an associate professor at Oregon Health Sciences University and is a practicing OBGYN. She will be joined by Dr. Carpenter, who comes to us from the University of Missouri, Kansas City School of Medicine. And you can read her huge list of credentials. For the sake of time, I'm going to keep us moving through that. But thank you to them both for joining us today as our faculty to share their expertise in shared decision-making. Our program agenda, we are going to have this brief introduction, and then the two presenters will be sharing with us their background on shared decision-making and a case study. When we get through that information, then we will be, like I said, pausing the recording for an opportunity for questions and group discussion, and then reopening that at the end for any final information to share out with you all. The learning objectives for this event were shared in advance, are available on our NHF site, and were also shared with you via email. At this time, you're going to see come up on your screen some polling questions. We ask that you participate in the pre-event poll and the post-event poll. It just helps us be aware of everyone's knowledge and understanding of the topics. These are anonymous polling, so that's not going to be connected to you. So please take a second. There should be polling on your screen. Answer the true-false questions if you would, and there's a scroll down feature. Please note there's 3 questions. So for our audience participants, thank you. Somebody has jumped in and started answering. Perfect. Thank you. I think we can go ahead and share out those results. It's always great to be able to just briefly see the difference in people's knowledge going into something. Again, that information is anonymous for each of you, but thank you for answering those questions. As we're moving through the presentation, we ask that you please post your questions in the chat. Jonathan from NHF will be giving you prompts and reminders to do so, but we will have, again, that opportunity for question and answers, and the faculty will be able to see your questions as well. In addition, at the end of their presentation, we will have that opportunity for discussion, and we really do hope that each of you will participate and turn on your camera and engage in a back and forth discussion with one another as well as with the faculty, not just have a straight question answer type of session. So that collaborative learning really involves getting each of us to talk to one another. So we thank you very much for joining us today. And with that said, I'm going to turn this over.
Hi, everyone. So we, as a surgeon, we get taught how to do informed consent with patients, and generally informed consent contains 4 components: the procedure, discussing what's involved in the procedure, the alternatives, like what could you do instead, what will happen if you don't have the procedure. Marcy, can you go back to that informed consent slide?
Right, I'm not sure why it's moving. There we go.
Thanks. And then we also bring up the risks, the potential risks, including mostly the common side effects and outcomes, as well as rare risks and the implications of them. And then we make sure we leave time for questions. So that's the informed consent model, and that's what's on really any consent form that a hospital has created. And when you think about all the opportunities we have for providing all these elements of informed consent, when we're doing something as simple as maybe a COVID vaccination or discussing a new medication. We employ those different components a little differently throughout decision making when it's a surgery or procedure versus really more of a small intervention without potential huge risks. So the amount that we employ that PARQ, or the informed consent, it really varies. We're going to really focus on the way that we apply informed consent to decision making about reproductive health options for management of periods, just because that's the topic we want to narrow in on today. But I think in our discussion, we should really, consider how these elements could apply to other parts of decision making that we discuss with patients in our practices. Next slide. So what is shared decision making that we're going to talk about today? It's a model where the patient and the provider are involved in treatment related decisions. There is a bidirectional exchange of information, and the preferences result in a mutual agreement on a course of action. And this, let's just, apply maybe to an outpatient decision about management of periods. So I would like to, really bring up here that the provider is also involved in this decision. And one of our pretest questions asks, does the provider get to say what they think? The answer is yes. We'll go to next slide. So shared decision making as a model is rooted in patient autonomy and the right to make informed decisions. It's a key aspect of patient-centered care to make sure that the patient has a voice. What's important is that we're respectful and responsive to individual patient preferences, needs, and values, and that's a key component of autonomy. The patient value will guide all clinical decisions, regardless of whether it's a provider value. And the goals are to increase patient involvement in their care, strengthen the clinician-patient relationship, and result in potentially greater satisfaction and engagement in care and in the recommended behaviors on the part of the patient. Next slide. So if we think about counseling models through time, particularly as they relate to reproductive health counseling and, for example, contraceptive methods, we really have had, a range going from really paternalistic model, which is employed in a lot of the world still, where the provider says, you need this, and here's the prescription, please start taking it. There is a provider-centered model where we started saying the provider would provide information, but the patient would maybe ultimately make the decision. So the provider would say, I really think you probably need some management of your periods because they're really heavy, and I think you should use this medicine. What do you think? And then the patient will, in this power differential, usually say yes, but maybe without as much information and maybe still with questions. And then there's a patient-centered approach where the patient has what we assume to be an informed choice or an autonomous decision. Maybe the provider provides information, but doesn't at all participate in the decision. So the provider might say, well, here are these options. Here are the different things about them. What do you want to do? But the provider in that model doesn't actually tell the patient what they think would be the most important or recommended. So it's really a little more unilateral on the side of the patient, but with that information. A model where it's both patient and provider centered is what we're talking about, shared decision making, where there's a mutually agreed upon decision reflecting both the preferences of the patient as well as medical evidence and the recommendation of the provider. And this seems really similar to patient centered, but we'll talk about how it's different and actually how to employ it. Next slide. So other models that are out there in the world of contraceptive counseling, I just want to bring up because they have some specific names and they're not necessarily not shared decision making, but you might come across them at some point. And it can kind of open the conversation of how these models can look differently. So foreclosed counseling is where you're restricting to limited methods without interactive counseling. So for example, in contraceptive counseling, you might say, I work at a clinic where we only have prescription-based medications. So you can have any of these, pill or patch or a ring, but there's not an interactive counseling. It's sort of just a menu approach to what's available, or maybe even what's available just under their insurance plan and not talking about other things that are out there. A rights-based framework is a model of counseling where all aspects of a whole program are held to a human's rights lens. So, for example, the way that patients are approached, the way that they're asked about whether they want to have counseling or not, the way that that there are, the way that access is equitably distributed, et cetera. And then there's tiered effectiveness counseling. That's a model where counseling is prioritized in the effectiveness model. So there's usually some review of what would be safe for the patient, and then first the methods that are the most effective are presented, and then down the tier. Gather is a model of counseling, and it's a little bit more pertaining to what happens in the visit. So for example, most tiered effectiveness counseling models have been researched using the Gather method of collecting patient preferences. So where first there's greeting the patient, asking them what they want, telling them information about the options, helping them get to a decision or to understand how they would interact with the medication, explaining how to use it, and then offering a return visit or follow-up of some sort. Preference sensitive options are when you only end up talking about the initial preference. So, so for example, medical assistant says, patient, what do you want to use for your period management? And the patient says, I want the pill. And then you come in and you talk about the pill. We want to keep in mind that research evaluating shared decision-making counseling and methods are based on these one-time decisions, but reproductive healthcare decisions are usually based on prior experiences. So research on shared decision-making in really all of medicine, but in particular in reproductive health, is really limited by this prior experience factor that we haven't really well evaluated yet. Next slide. When we think about the ways that decision-making can happen, they're kind of separated into these two models of normative versus descriptive. Normative decision-making assumes that individuals follow a rational, systematic process of like, here are my options, here's the pros and cons of them, and I'm going to rationally decide what's best for me, and then here is my decision. A descriptive model of decision-making recognizes that decision-making is heavily dependent on personal, social, and environmental factors. And I think that's just really important to keep in mind, because we really do sometimes write down the steps of decision making and think that they're very linear, and actually they're really not. It's also an important thing to remember that information exchange is very imperfect. So when we provide information to patients about options, it's not necessarily meaningful, relevant, or understandable, especially at the timing or the amount of information or the literacy level that we present it. Accessible information can be presented or processed in an incomplete or biased manner. That the way that we present information has differences in social acceptability, affect, and environmental and contextual cues, and that how content is delivered and the need for culturally appropriate communication is really important. So the context around this information exchange is really fraught, and we're always imperfect about it. We just have to accept that. Next slide. So in the shared decision-making process, individual models of decision-making that apply to the patient and provider, and each is affected by constraints and expectations, not just of the interaction and how much time you have, but also of the whole healthcare system. What's available and accessible at your site? What are the, what's the knowledge about cost, and how is that available to the patient? And so the whole healthcare system is this umbrella focused down on what's happening in the patient-provider interaction. And of course, the clinician's cognitive style, social situation, their prior experiences, we set the tone often. Risk perception from the patient's perspective is dependent on a lot of factors, their prior experience being one of them. And then, of course, cultural influences on the way that their biases and previous knowledge or previous experiences really plays a role too. Okay, next slide. Just want to mention the concept of therapeutic alliance, which isn't so much a counseling model, but it is a very similar framework to the shared decision-making framework. And this initially arose from psychiatry. So it was a dynamic interactional process in which patient and provider collaborate to carry out negotiated mutual goals in a shared partnership. And this is the framework of many other kinds of, counseling and therapy relationships. And that concept encompasses the way that communication happens in that relationship, the integration of knowledge, collaboration, follow up on collaboration, and patient empowerment for decision making. And so it's a very similar model. It's not separate to call something therapeutic alliance. And but I just wanted to highlight it because next slide. Because there is actually a fair body of research on outcomes related to therapeutic alliance and how that alliance is very beneficial to success with outcomes. So it's been associated with improved adherence, improved outcomes in general, patient satisfaction, and patient-centered communication. So when we say we hope that having a shared decision-making therapeutic alliance will result in improved patient adherence, it's really based on this body of research. Next slide. But there are huge barriers to implementing shared decision-making in a real way. And that really is related to the part of the patient really taking an active role. And so leaving space for patient empowerment is really a prerequisite here, but we infrequently really promote that empowerment. There are also big differences in relational decision-making across cultures, changing circumstances on behalf of the patient. And then the provider may be just inadequately prepared to deal with the way patient time needs to be taken into account to make decisions and behaviors, et cetera. And of course, the system is not at all designed to support collaboration in a 20-minute visit. All right, I'm going to turn it over to some realistic, case presentation and examples, and then we'll come back to what does the visit look like to do shared decision making. And I'll turn it over to Shannon.
Hi, thank you. Great. I mean, this has been, I always think about this a lot more when I start to think about the process. We do this in our practice, and it sometimes comes just as part of our natural flow of how we interact. But I think when we think about it and are very intentional about this kind of approach, it can be really beneficial when we run into kind of stickier situations. And I've presented one here. So this is a 13-year-old with heavy menstrual bleeding and von Willebrand disease. And she's responded only partially to hemostatic treatment. So she still has her menses lasting 10 to 14 days, though it's lighter and she's not as anemic as she had been when she started her von Willebrand focused treatment. Her parents, however, wish to avoid hormonal medications. But being a good adolescent caregiver, you interviewed the child in private. And she asks about the pill when you're in private, as she's heard about some of her friends using it, and it makes their periods a lot better. She heard about it at camp when she was there for hemophilia camp. So next slide. So we need to think about adolescent development. So in these cases, there's a number of different theories on adolescent development. And if anybody actually understands adolescence, let me know, because I've got two at home. But these are how different psychologists viewed development. And you can see, Freud had his own way of thinking about these things. But Piaget and Erikson, I think, have a little bit more up-to-date views on this. But the idea being that children naturally go through developmental stages. And early on, they're really just learning about their world and how they interact with it, and really just getting the concept that they are a separate entity versus their surroundings. But then in the adolescent ages, you really get to the point where they're starting to form their worldview. They're starting to have their own values that may be distinct from their parents while they're still under their parents' roof, and parents still have custody and medical decision-making capacity for them. And they really are trying to form themselves as an individual at this point. And of course, all through that, they're going through significant physical and hormonal changes where their body's changing, their interaction with the world is changing, and their brain is changing, and as part of their body. And so how they are taking that in is variable to each child. Next page, please. So focusing a little bit on Erickson, the identity role versus confusion. So you'll have some kids who have a really strong sense of identity. They know what they want. Others are much more confused about where they fit, or whether they want this, or their peers or their parents want this. And so there can be not only confusion for the child, but they also may go back and forth. They may at one point want something and then change their mind based upon other influences or development. Noam looked at early adolescence as being more concerned with group cohesion, and you can see that in peer groups and how all the kids like the same YouTube videos, or they like the same band. And younger adolescents are more susceptible to peer pressure. There's good data to support that. Whereas older adolescents appropriately become more resistant, and they are interested in forming their own identity. Next slide. Another way to think about this is, how do adolescents develop formal operations? So, consequences. How do adolescents look at consequences? So we think hypothetically, if I do this, then this will happen. Now, if you've known a few adolescents, that isn't always in operation for every time that they do something. And so that is kind of the first way to develop formal operations. You can think logically. You can identify and reject hypotheses or possible outcomes. So rather than having to do the thing and then find out what happens, or if I do this, you can think about options of what might happen. If I make dinner tonight, mom might be happy. If I burn down the house, mom won't be happy. If I hang out with these people, these are the options of what might occur. And if I don't hang out with these people, these are the options. And then you reach thinking about thought. They're analyzing themselves. Why did I do that? What was I thinking at that point? How am I going to help with that? How does that help me do what I want to do? And then they start to have insight and perspective taking, and they can look at what other people do and why they do those things, consider their perspectives and perspectives on the social systems. And you can see how this is advancing through development on how they might make decisions. So they might understand that their parents' values are different than theirs, but they may or may not be able to either clearly enunciate why that is, or why they think differently, or be able to think of it in a formal way for how they would solve their problem. And then you get to systematic problem solving. The kid who can figure out, well, I see this problem in the world, I'm going to go and here are the things that I think could benefit this. And that's, of course, where we're all hoping to get to at some point in our lives, and with varying degrees of success. Next slide. So because of this developmental gradation that occurs, adolescents have this sense of invulnerability, and they can't actually always grasp the results of all their actions, if you think about the previous slide. And naturally, they should feel invulnerable at this age. I mean, you've got to feel that way at some point, right? But there's actually a biological basis for this. The prefrontal cortex of the brain is the last to mature and last to myelinate with an increase in white matter. And and there may be actually some neuronal pruning that occurs around the same time in adolescence. So that the frontal cortex, the decision-making portion of the brain, really isn't fully developed until late adolescence. And it varies depending upon what you might think of as adverse childhood experiences. Those kids may develop differently or aberrantly. They may have aberrant coping mechanisms depending upon what they've learned from people around them, or they may have seen more risk-taking. And of course, there are genetic issues in terms of psychiatric illness, potentially. So these red flags for people who might be more impulsive and risk-taking are listed there below. And you can think about, others that might occur, certain familial stressors and those kinds of things that might influence a child to be more, have more risk-taking and more impulsivity. And this has to do, again, with how they adhere to their medication treatment as well, because that may influence how you're helping them to make decisions within the shared decision-making process, and how shared you can be with an adolescent in conjunction with their family in the decision making, because you have to kind of assess where each adolescent is in this kind of continuum of development. Next slide. So as I mentioned before, perceptions of the stage of adolescence, it's influenced by cultural norms. There are some cultures where adolescents are really very responsible, 15, 16 years of age. Kids were married at that point, at some point in history, and still are in some areas. And so I think that you have to consider the cultural norm. And even within cultures, and I think we can all reflect on this, there are adolescents who maintain a more childlike relationship with their family compared to others, depending upon the societal situation that they're in. And development's not linear. Adolescents will still be influenced by their parents and other trusted authorities well into their young adulthood. And maybe that's not inappropriate. And that'll vary depending upon the situation. They may become more dependent in times of illness or other things that might make, or stress that might make them regress. And again, that may not be inappropriate depending upon the situation. And of course, physical illness can greatly impact an individual's self-esteem and autonomy, even if it's not visually apparent. So a girl who has had multiple episodes of heavy menses that kept her out of school, had multiple infusions or transfusions, she's going to have a different view of her body than someone who's maybe not suffered those setbacks in their health. Next slide. There are some legal aspects of adolescent medicine that I think we need to consider when we talk about shared decision making with adolescents, particularly around the subject of contraception and reproductive health. So consent for contraception differs from state to state. In most cases, in most states, the discussions can be done privately, but it's important to know what it is for your state. And in my case, there are two different states. So I have to know the state of where the child is in residence, not just where I am. Of course, other medical decisions usually require parental permission unless the adolescent is emancipated. And there are varying rules from state to state on what constitutes emancipation. And so you have to really talk to adolescents about when their confidentiality must be breached and be very honest and transparent with them. Now, of course, once adolescents, unless they are developmentally delayed and the parent has made gone to legal steps to get prolonged care of that patient, of that person, an adolescent must be contacted directly after 18 years of age. But usually, even in that case, they can give permission to a parent to still be involved. And I know in our hospital, they can set their parent as their medical decision maker even after 18 years of age. So it's important to know all these ramifications. Sometimes adolescents will present to a clinic without a legal guardian. You have to know whether or not that is appropriate in the setting that you are in. Next slide. So this is as of January of this year, the state laws regarding contraception for minors. And I specifically looked at this for the purposes of this talk, but you have to consider that this is going to be more liberal than other medical decision-making that adolescents may be interested in making. So 23 states in the District of Columbia explicitly allow minors to consent to all contraceptive services. 24 states, and you can see here, permit in one or more circumstances, and you can see some of the limitations here. So again, if the minor's married, they can consent to contraceptive services in 19 states. 5 states who allow a minor who is a parent to consent. Deeper sigh. And 5 states allow a minor who has ever been pregnant or is at that time to consent to services. But then you can also see some of the other criteria that would allow a minor to consent to treatment from a specified professional. 4 states have no explicit policy at all, leaving you in kind of a legal gray zone in those cases. Next slide. So this goes along to, I think, the gather statement that Dr. Baldwin was referring to before, but utilizing this in the thought of a adolescent. So it's helpful to be a little immature like me and talk like an adolescent, but acknowledge the need for confidentiality. And again, make sure that you know when you cannot keep that confidential, whether, if there were reports of her hurting herself or others, you may need to break that confidentiality. Remain unbiased, non-judgmental, And then they have some details here about what to ask. But, you know, sometimes when I have girls talk to me about wanting a pill for their period, you know, it's important for me to ask, are you also sexually active? Is this something you need for contraception as well? Because they may not want to be forthcoming in that, thinking I may judge them in that area. And then understanding what her understanding is of sexual development and risk for pregnancy. There's a very large variation in what young women and others with propensity for menstruation understand in terms of their risk and whether or not they can get pregnant. We also have to consider, it's important to ask if they're dating, not to be judgmental or assume who they might be dating. And so we ask very open-ended questions about who they're having relationships with in a way that does not presuppose a heterosexual relationship. So all of these things are really important to set that trust and to allow for open communication. And then when you're talking to them about contraception, you have to be very explicit about how it works and how they use it. Again, through that formal operation development, sometimes concrete thoughts are still very present in some of the younger adolescents. And so if you need them to take the medication at a certain time each day, it's important to communicate that with them in a very clear method. And also address some of the concerns they may have that may seem maybe not irrational, but like unexpected. Sometimes there's a lot of things on TikTok and YouTube, a lot of misinformation about contraception and other medical treatment that, you know, if you don't ask, they may not tell you. So it's important to remain very open-minded to things they may say and answer those honestly and respectfully because they're willing to ask you. Next slide. So I will hand this back over to Dr. Baldwin and she'll bring us on home.
Thank you. I'm so reflecting on all of the interesting myths that I've heard from teens. So I'm going to just walk through what does a counseling encounter look like, and in particular with a teen for shared decision making. And the way that this was, this model was created was based on at UCSF. A qualitative study of 40 contraceptive counseling interactions. And I will note that this was with adults. So this model is actually not really validated or practiced in younger adolescents in particular. And so they looked at these contraceptive counseling interactions performed by people who do them a lot. And then they stratified by whether a preference was indicated prior to the interaction. Like, I'm coming in to talk about an IUD, and then they have an interaction, and they'll stratify those into the preference-based ones. But the components that they came up with after observing all of these interactions were that there was this initiation phase, like the gather greeting phase, and then the information sharing, deliberation, and decision-making were the main components of the SDM. Next slide. And so if you break this down into kind of a wheel of all of the elements that really need to be there at some point, we start on the upper right where there's a question about reproductive goals. And that could be about menstrual goals if we're just talking about menstrual management. But as Dr. Carpenter said, we really need to also bring up, you know, is contraception something we need to talk about today? And I usually start doing that around age 14, depending on the patient. And then we talk about risk. And so that's where you do your medical evaluation of, you know, is estrogen contraindicated for this patient or not? Are there other medication interactions or metabolism concerns? Do they have a G tube? Can they swallow pills? You know, those kinds of things. And then, and in an adult, that might be equipoise about their reproductive history and their risk for conception or the risk for, you know, evaluation for other reasons for heavy menstrual bleeding, et cetera. And then you move on to exploring the patient's values and concerns, and then potentially listing options or showing a picture of options or having some interactive demo of options that also includes side effects and effectiveness. And we'll go over how that can be an iterative process. And then check the understanding, negotiate a decision, review the plan. Next slide. The initiation phase, of course, is just the welcoming phase, as Dr. Carpenter went over, and asking, establishing rapport. It's surprising to me how very short this can be to create rapport. It's simply like, do you have any pets, or what is on your t-shirt? And I feel like that's one of my favorite parts of the visit, but I think we all really need to spend a couple moments on that with every patient. And then ask open-ended questions, some more focused. I like to start with, not just what brings you in today, but, what are you thinking so far about, what do you know so far about what you're interested in talking about? That gives me a lot of information about where to start with a baseline. And then when we're talking about method features, rather than methods, we want to really focus on really what are the expected outcomes rather than what is the actual medication or what is the actual method. Because I think especially with adolescents, since they're really focused, on the whole experience, and they're not really concrete, their concrete thinking is different. We want to really just kind of get them to focus on what do they expect to happen. So what happened with your bleeding after you tried that one? What did you like about it? What did you not like about it? Could you tell me more about why you stopped it? That gives us a lot of information about this patient will not tolerate any unexpected bleeding, or this patient has very heavy bleeding and all they want is a decrease in the amount of bleeding, or this patient really knows that they cannot tolerate a pill or that they can't even swallow a pill. And then we'll always want to confirm safety. Next slide. Some of the information sharing back and forth, I'll start on the right column here. Things that are shared by the patient, of course, preferences about bleeding, preferences about side effects. And if they're not openly sharing them, I try to enhance the opportunity for patient autonomy by really just saying, tell me everything that you want to tell me about your preferences, about side effects, and about what you've heard or what you know about that. They may just give you a reaction to information you're giving them, and that would be information sharing. Like they're going to just be like, no, I'm not having a public exam ever. And that would be an important piece of information. They might share their goals or concerns. One thing I think is really helpful is understanding, like, what do you know? What have you heard from your friends? Because that's such an important influence on whether they'll want to participate in that treatment plan. And then some social context. What are other people doing that that you've heard of? What have you read about? Things that the provider would share would be efficacy, side effects, additional benefits. I would share even what I think would work best for you, or what you're telling me sounds like that you would really be, that this method may work really well for you. We might talk about mechanism of action, explanation of use, cost, access, and we in particular should really actually emphasize myth busting. I think one thing that patients, particularly adolescents, sort of think they're doing when they're having this discussion is they think they're signing up for a long-term forever plan. And I think it's really important to myth bust, to say, really this is just this medication is short-term. It goes out of your body very quickly. And if you're not happy with it, you just stop it. And I think there's this sense on the part of particularly adolescents that once they try a medication, that there's something that's changed about their body forever. And we have to kind of dispel that myth. Next slide. The really, really important part of SEM is deliberation phase. And this is an iterative narrowing of a shared list of method options. So it's discursive. So this really differs from the sequential model, where I list all the methods, I list all the effectiveness, I list all the concerns and side effects, and then I'm like, what do you want? This one is like, tell me what's important to you. Okay, well, the important, if not having any unexpected bleeding is important to you and you can't take estrogen, here are really the only options that would give you that. And then I narrow the list to the preference important things about bleeding that are for that patient. And then I might mention, well, if it's not as important, if you're not that worried about having some unexpected spotting, there's also these other options too. And so we could kind of leave that list and go back out again if we, hear something from each other where the patient says, well, I guess I could tolerate that a little bit. We really integrate that deliberation into the information sharing. So it means that you might not cover every single option or every single detail about every option, but you narrow it based on the preference for the patient. But we still provide recommendations, and we still talk about safety, and then we want to make sure that we leave room for the patient to say their concerns or their questions. And then during that process, really important to suspend judgment about what the patient knows or understands, or what their myths might be, and to check our bias on what we're offering based on what we think the patient might want. Next slide. The decision is ultimately deferred to the patient, and so we explicitly acknowledge that they have decision making. So we could say, I think that there are a few options that you would probably find better because of these reasons, but it is really up to you, and really any of the options are on the table. And then say, are you ready to make a decision today, or do you want to go home and talk to your parents about it, talk to your friends about it, read more about it on this specific website that has accurate information? And they may say, I'm ready right now, I totally know what I want. And I've often been surprised at their answer, or they might want to go home. And then we would reinforce the reevaluation phase. So at that point, say, are you ready to make a decision? And just keep in mind that this decision is, you can change your mind later. We don't have to stay with this method if you don't like it. I think giving them that out is really important. And then following up with education once they've made their decision, just really going through adherence and success for side effects and anticipatory guidance about what to do if. Next slide. The downsides of SDM are that when there's so many choices and lots of information, we can't review it all. And so we might miss one of their really important preferences. They might have a preference that they say they want that is misinformed by their social networks that we don't catch. There might be gaps in knowledge at the end of our discussion, and we can still introduce bias and coercion. Next slide. Bias and coercion are really prevalent in reproductive health counseling, and so it's really important that we own it, and we know that it's happening, and that we really try to be aware. So we have plenty of evidence of coercion occurring today, and not just actual coercion where we're forcing people to do things, but really subtle ways of coercion where in the method preferences we offer, or the emphasis that we place on certain options, leaves people with a feeling of coercion. And it's the perception of coercion that's the most important thing to pay attention to. Next slide. But there's actual objective evidence about coercion occurring in contraceptive counseling, and importantly, this comparison of patients looking a certain way for high or low socioeconomic status was not as didn't result in as different counseling as much as Black or Latina patients. And in these counseling interactions, IUDs were offered more often to people at lower socioeconomic status who were Black or Latina rather than white patients. And the reason why we think this happens is that, number one, providers want to have a perception that maybe patients might have this opportunity to have this option at this time. And so we're trying to equal the playing field and say, hey, you could get an IUD for low cost. You should have it now if you want it. But also that there may be a perception on the part of the patient that we don't think they should be pregnant. And so those things, even in the best interest, can be misinterpreted. Next slide. There's, of course, many common assumptions. The patient will never remember to take a pill, so I shouldn't recommend a pill. She's already had 3 kids. She can't want more. She definitely wants a permanent method. She's asking for birth control, so she must need contraception, instead of just the fact that birth control is a euphemism for the pill form of hormonal medications. They experience side effects from the pill, so they'll probably want a copper IUD instead. Or they had an abortion, so they need better birth control. That one wasn't good enough for them. So these are very common and prevalent assumptions that we need to pay attention to. But all those things aside, we should come back to talk about questions about how we can implement or barriers to implementation of shared decision-making in clinic. And I'll turn it back to Marcy.